Hi, this is Brian Kim. I want to share with you this case of a patient with a very deep set eye. You're going to see how I'm going to be working in a hole, and this also requires a more vertical approach to the instruments. You're going to see also this patient has a strong Bell's reflex, and it is a 2 to 3 plus dense lens. And when I'm going to perform the double chop, you'll see the lens tilt a little bit. And the question is this dangerous when it tilts like that? I've been, again, encountered some criticism, people voicing their concerns about mechanical fracturing, and I'm going to explain to you why I think this is not actually a dangerous situation. So you can see this patient has a very deep set eye. And now this is the patient's eye under the microscope. You can see he also has a strong Bell's reflex. He's squeezing and looking upward as I turn the microscope light on. And you can see I'm trying to open the eye as much as I can. This patient, again, I'm having to approach the eye in a more vertical orientation because I'm working down inside this hole. So I use a cotton tip to steady the eye. This is a corneal marker, which will help me to center and size the rectus. You can see there's water pooling, so I'm using the cotton tip to absorb that water because there's so much pooling there. Using the cotton tip to hold the eye, I'm going to make my paracentesis incision first on the right side and then the left side. You can see how I have to turn the eye in such an extreme manner so I can get a nice flat approach with my blade. And so first on the right side and then the left side. This one's a little bit more of a challenge because the patient has to look down because this is the right eye. Holding the eye steady, asking the patient not to move, and I get a nice flat approach, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. I'm using the cannula to hold the eye because, again, this patient has a strong Bell's reflex. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then when I'm ready, I turn the eye slightly towards me with the cannula, and then I enter. Now these are the sharp tip Haldi Percar forceps. I go in with the teeth sideways. Puncture the center. Pull down towards me, pulling on the tear little by little to extend it. And then once it's the right length, I'm going around circumferentially, and that kind of sets the radius of the rexus. Try to go around circumferentially, matching the rexus to the corneal mark that I made, which will hopefully allow me to achieve a well-centered and sized rexus. Finish off the rexus, burn some viscoelastic out. And this is the capsular fornix hydrodissection technique. I place a cannula under the rexus edge, contra-incisionally, point the tip down, get a nice wave. That was a pretty fast wave there. Decompress on the left side, sweeping underneath the anterior capsule edge on the left side, doing the same thing on the right side, and the lens begins to spin. Irrigating the surface of the eye, adjusting the sleeve. Asking the patient to look away from me. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. Again, a more vertical approach with my instruments because of this deep set eye. I'm placing the chopper under the rexus edge contra-incisionally, the ficca tip vertically sub-incisionally, bringing the instruments together, crushing the lens from either side, and that is the double chop maneuver, placing the chopper around the right heminucleus, pulling it centrally towards the ficca tip, hooking the peripheral lens, crushing it against the ficca tip, and that is the cross chop. Using some vacuum to lift that first quadrant up, crushing the lens with the chopper against the ficca tip, and then emulsifying the lens pieces. And so you can see this is a beautiful illustration of the technique, but I did it fairly quickly here, and I want to show you in slow motion that the lens tilts a little bit. And so here we go, pronating my instrument, sliding it under the rexus edge contra-incisionally, holding it vertically. I'm at the level of the equator, turning the ficca tip vertically sub-incisionally, encountering and holding and gripping the lens from either side, bringing the instruments together, and then fracturing the lens completely in half. That is a double chop. But if you see very closely when I do that, there's a slight tilt. I'm placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip, and crushing the lens against the phaco tip like it's a chopping block. And so what do I mean that it's not dangerous? People are afraid that, you're using mechanical forces and the lens does a tilt like that and it's going to cause zonular damage. And that makes absolutely no sense. Remember, the peripheral lens is rather soft. And so when you have this large capsular bag and the peripheral lens is rather soft, and that's why you're able to remove the surface epinuclear material with vacuum. Remember, the peripheral lens material is soft. So when I'm fracturing the lens, even though it's tilting within the capsular bag, but that tilt maneuver is just encountering that soft epinuclear material. It's fluffy. It's not putting any traction on the zonules when you do that maneuver. If you assume that the center of the lens doesn't move and the lens is tilting, it's really pivoting around that central aspect of that lens. And so again, tilting of the lens within the capsular bag is not dangerous to the eye and it's not dangerous to the zonules. You saw that I hooked the peripheral lens around the second quadrant, crushing the lens against the phaco tip and then crushing the lens into smaller pieces and emulsifying the lens pieces. You can see and feel that there's a rather dense tactile sensation when I'm fracturing the lens. There's a sudden loss of resistance every time I fracture the lens. And again, because I'm utilizing mechanical fracturings to fracture that force, that energy that's required to do that is just with my instruments. The energy is not with ultrasonic energy, and therefore less damage and potential risk to the corneal endothelium. So I turn that second heminucleus in front of me, placing the chopper around the lens at the equator, pulling it centrally toward the phaco tip, fracturing the lens in half. Again, the phaco tip acts like a chopping block. Doing the same maneuver around the third quadrant, doing the same maneuver and pulling that chopper toward the phaco tip and fracturing that third quadrant again. Again, the chopper is almost acting like a knife and the phaco tip is acting like a chopping block. Using mechanical forces to crush the lens into smaller and smaller pieces and then emulsifying the lens pieces. Again, using pulses of ultrasonic energy as I do this to emulsify the lens pieces and then using crushing forces to break up the pieces into smaller pieces. Using the chopper to hook that last piece around the equator, pulling it centrally toward the phaco tip, crushing the lens in half, using mechanical forces to crush the lens into smaller and smaller pieces, and then emulsifying the lens pieces. You can see, even when there's a free-floating piece, just like I did with that maneuver, you can see how you can just hug that lens with the chopper, hooking the peripheral lens, and then positioning the chopper and the phaco tip around the lens piece and then just crushing it. Again, when you use equal and opposing forces, this is very controlled. There's no traction on the zonules. There's no vacuum needed. There's no ultrasonic energy needed. You're just using mechanical forces to crush the lens. And once you crush the lens into smaller and smaller pieces, you can use pulses of ultrasonic energy to emulsify the lens piece. So again, this was a rather dense lens, 2 to 3 plus, and the CDE is 3.14. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start sub-incisionally, removing the epinuclear material and cortical material from anterior to posterior. And then I'm going around circumferentially, removing again from anterior to posterior. This cortex is really attached to a very thin layer of epinuc, so it's really kind of stiff, which is fine. And then I go switch to polish mode and start polishing underneath the rexus edge. You can see that fine wispy lens material that's still adherent to the capsular bag. Polishing the posterior capsule as well, again, very safe with this polymer tip. Polishing the subincisional posterior capsule as well. Again, there tends to be some fine, wispy lens material, cortical material that's adherent on the capsular bag sometimes. And I like using polish mode because it's very gentle and safe, and you're not having to utilize high amounts of vacuum this way. Pulsing into the subincisional capsule fornix with the BSS cannula. It's nice and clean there. You can see how much pooling I'm having with the water. Do you see how much water there is covering the eye? This eye is literally like a submarine eye. It's like underneath the water throughout the entire case. Filling the bag with cohesive viscoelastic, sweeping underneath the rexus edge. And I know it's not that obvious in the videos, but certainly in the case, you can see there's just so much pooling. And again, can be a challenge. But as you saw with this maneuver, with double chop and cross chop, absolutely no problems with performing this case. You do have a more vertical approach because you have to hold the instruments a little bit more vertical, and you're working in this hole that also did cause that lens, again, to tilt just a little bit, but not really a terrible amount. And more importantly, if it's tilting and pivoting on that central axis, again, there's no translational movement. The lens is not moving left, right, up, or down. It's just rotating. It's not going to cause any zonular stress. Again, the peripheral lens is soft. This is quite different from if you had this super giant, like hypermature cataract, where the entire lens is dense. I think that would be a different situation, and that's why it makes sense to debulk the central lens with sculpting in that context. But this is not that case. And you saw I was able to remove the surface epinuchal material with vacuum. If I can do that, that means the lens material is soft. It's like dealing with Jello. You're able to compress and cut through it very safely. And so when the lens tilts like that, again, it's tilting along that axis. It's not moving side to side. It's not pushing on the zonules, stretching the zonules. This is a very safe technique. Again, very versatile. And you're able to see how deep set this patient is. Again, I'm working underwater. You can see all that water accumulation, but it really has no bearing on my ability to disassemble this lens. Even though I'm working underwater, I'm able to very effectively disassemble this lens, performing double chop, cross chop. And again, using mechanical forces and leveraging mechanical forces, I'm able to utilize less ultrasonic energy. This patient had a really nice clear cornea postoperatively and seeing well. And that is why I feel double chop and cross chop is really the best way to perform lens disassembly. You're using the same instruments you've been using all along. You don't have to buy a different piece of equipment or instrumentation. It does require a nuanced change in the way you approach lens disassembly, since you have to use the phaco-tip like a chopping instrument. So it's a little bit of a different way to think about it. But when you're able to think differently and then use the instruments to crush the lens, mechanical forces, situations like this where you're working underwater in the deep set eye is absolutely no problem. You're able to very effectively disassemble the lens in this deep set eye, even if you're working underwater. So I hope this was helpful to you, and I thank you for your attention.